Today's episode is entitled COVID-19 Therapeutic Update. And our objective is to talk and discuss what is the state-of-the-art treatment of COVID-19 patients 6 months after the start of the epidemic, at least in the United States and globally. And for this, I have the pleasure to be joined by two very distinguished guests. The first is Dr. Henry Masur, who is the Chief of Critical Care Medicine Department at NIH Clinical Center in Bethesda, Maryland. And he's the co-chair of the NIH Therapeutic Guidelines for COVID-19. And then Dr. Adarsh Bhimraj is the section head of neurological infectious diseases at the Department of Infectious Diseases Cleveland Clinic in Cleveland, Ohio. And he is the chair of the Infectious Disease Society of America Therapeutic Guidelines for COVID-19. Welcome, gentlemen.
Thank you.
Thank you.
So today, due to all the developments and recent developments that we've had in treatment of this disease that we are learning every day, is the idea is to discuss what is the state of the art today. We are recording in July 2020, and what information has been provided now to everybody around the world to treat this disease, and what advances we made, what we learned in many ways, particularly with the new agents that have become available or new strategies for treatment. So, and I wanted to basically divide this discussion in two different kind of patients. So patients that get to the hospital and maybe are not that sick, don't require oxygen, and the others that require different kind of oxygen and eventually end up in mechanical ventilations. So the first question is for Dr. Bhimraj, and I want you to tell us, according to your expertise and all the guidelines, at July 2020, what is the therapeutic approach to treat what we call non-severe COVID-19 disease at this point?
Okay. So first of all, thank you for inviting me, and it's an honor to be with you and Dr. Masur on this podcast. Now, the question is, how do you treat non-severe or moderately ill patients who are hospitalized? I think if you look at more than doing a lot of things, it's about what not to do. As Hippocrates said, it's primum non nocere. Let's not do a lot of harm to these patients. So if you look at the data, and there is data about the use of hydroxychloroquine in this population, and it is not effective. So the first thing is, I don't think we should be using hydroxychloroquine in these patients. There's emerging data about Remdesivir, which is not yet published. I think my opinion is, I think we should still not be using it unless we see more data in moderately ill patients. And a few other things is, treat these patients supportive care. I think what is really important for these patients is supportive care. You can use acetaminophen, and even with non-steroidal anti-inflammatory, I think we have enough observational studies which shows their safety in this particular population. And again, don't stop their regular medications. If you're on an ACE and an ARB for any other indication like hypertension or like for renal diseases, or even for like heart failure, again, these drugs should not be stopped. There's a theoretical concern about ACE2 overexpression and the deleterious effects, but there are tons of observational studies which have looked at it and of the safety of these medications. So I think, so supportive care, not stopping medications which they're already on for their underlying indications, should be the most important care of these patients. And of course, a few common sense things like if the patient has asthma, and again, use metered dose inhalers and don't use nebulizers and things like that if you can avoid that, so that it's not just about the patients, but also making sure that the infection is not spread to people around the patients.
Okay, great. So if we may move in the spectrum of disease and we put saturation of oxygen as a good parameter that has been used in majority of clinical trials, we get into the realm of people that are going to require oxygen supplementations with a saturation probably less or equal than 94%. Dr. Masur, in these patients that eventually are going to need oxygen supplementation in different varieties, all the way to possible intubation, what will be the best approach therapeutically to try to, let's say, stop the disease process, avoid intubation, or maintain oxygenation in an optimal way to prevent further complications.
Well, Cesar, let me make an editorial comment and then I'll answer your question specifically. Adarsh was the chair of a guideline that IDSA put out that's been very influential. And there's also been an NIH guideline. And the question is, why do we have these guidelines and how should they really help us? And in many ways, although Adarsh and Cesar weren't alive back then, at the beginning of the AIDS epidemic, we were in a similar situation in which there was a disease that most people didn't understand. There was rapidly evolving information that was often out there in the popular press before it was in the scientific press, particularly then, since it took a long time for articles to get out. And there's a lot of confusion as to what to do. So I think for IDSA to put out a guideline, it was tremendously important so that people knew what the scientific evidence was. And for the government, it was also important because a lot of policy decisions obviously should be based on science. And it was important to get government scientists with representatives of various professional societies to make a determination of what was really science-based so that people could use that to make policy. And it's interesting if you look at how these guidelines are being used. I don't have the data for Adarsh's IDSA guideline, but there have already been about 3 million page views of the NIH COVID guideline. And what's fascinating is that while a lot of people look at the data on chloroquine, on Remdesivir, the most hits in the last few weeks have been on vitamin C, zinc, and vitamin D. The point being that I think these guidelines are important for exactly what Adarsh said, and that is so that we don't do harm or we don't spend a lot of time and effort on interventions that have no benefit. We need to know where there's benefit, and it's equally important to know where there's no benefit or where there's harm. And as Adarsh said, in the patients who are not sick, dexamethasone may well be doing harm. So in terms of saying, what do we do for the patients who are sicker, I think it's also useful to start with a little bit of a conceptual perspective, and that presumably early in the course of someone's disease, they have a lot of viral replication, which is eventually controlled by their adaptive immunity. As the disease goes on, they get inflammation, and it may be that we need to reduce the inflammation. So there's a viral phase and there's an immunomodulatory phase. So my approach, once somebody is beginning to need supplemental oxygen to get their PO2 or to get their O2 saturation at 94 or above, if they need supplemental oxygen, we know that remdesivir is important, and we know that dexamethasone is important. So each intervention is important. We're going to talk later about whether you should use them in combination. But the more ill someone gets, the more important it is to get them on dexamethasone, because we know from the trials we're going to talk about later that dexamethasone improves survival for patients who have high needs for supplemental oxygen and are on mechanical ventilation. It's not so clear that remdesivir is helpful once you're getting mechanical ventilation. So remdesivir early when you need low flow oxygen, dexamethasone more important the more oxygen you need, and certainly when you get on a ventilator. But I'd also like to say that while we're very pleased with the fact that we have an antiviral and we have an immunomodulator that are helpful, for patients who are in the ICU, we can't forget the supportive care. Traditional critical care is very important. So if we're really going to have the best outcomes, we need to make sure that we look at how we're ventilating patients, how we're preventing nosocomial infections, how we're preventing thrombotic complications, because we know this is an important part of the disease. So that, again, it's wonderful that we have these new therapies, but the major impact on outcome, I would maintain, has to do with supportive care. So that traditional ICU care is extraordinarily important in terms of improving outcome. Adarsh mentioned antivirals. and immunomodulatory therapy. Again, we also have to recognize that the use of anticoagulation is very important to these patients, and also the use of antibiotics. We know that antibacterials are probably not indicated early in the course of COVID. They're not necessarily indicated in somebody who's on a ventilator, but the longer someone is on a ventilator, the more one is concerned about ventilator-associated pneumonia, about line-associated infection, and we have to make sure that we recognize that and treat that as appropriate. So supportive care in the ICU is extraordinarily important, in addition to the specific interventions we're going to be talking about.
So just expanding a little bit about that, Henry and Adarsh, I would like you to expand a little bit in the anticoagulation approach. I mean, the pathophysiology of this disease suggests that is a very important component, but there is a lot of controversy out there on how to approach it. Is there any data that suggests what is the right approach for anticoagulation?
I don't know whether Adarsh wants to take. Let me take the first stab, and then Adarsh can correct me as we go along. But I think that everyone who has taken care of COVID has been impressed that some of the patients have thromboses of their lower extremities or upper extremities. People who have taken care of COVID are impressed that they have seen patients who've had devastating pulmonary emboli or cerebrovascular events. So these are things that we need to avoid. I suspect that when you talk to practitioners in New York or California who've had a lot of experience, almost all of them believe firmly in anticoagulation. What is not clear is whether you should use prophylactic doses, full therapeutic doses, or something in between. And most experts, I think, would support using a directly acting oral anticoagulant so that you don't have to go into the room often to use unfractionated heparin and to adjust the dose. So I think that anticoagulation for patients in the hospital is important. It's just not clear to me what the dose should be. And if you look at the American Society of Hematology guidelines, they say specifically that all hospitalized patients with COVID should get thromboprophylaxis unless they have a contraindication, but they don't make a specific recommendation as to how much. So Adarsh may have more information to expand on that.
Thanks, Dr. Masur. I know serendipity. We just had a call with a methodologist and hematologist this morning discussing this question. We're generating the PICOs and doing the searches. But again, the bottom line is, Cesar and Dr. Masur, we all have taken care of these patients, and you know the data. It's a hypothrombotic state. These patients are more DVTs, more prone to Ps, and we all know that. And we also know that they have surrogate endpoints which are elevated, like D-dimers and a lot of these things. But the issue is, should they be treated any differently from our standard patients? We all have patients who use 30 milligrams of unfractionated heparin. Again, for me, enoxaparin. Regularly, if they're high risk, you're going to use 40 once a day or 30 twice a day. But what we have is much, much higher doses. Is it 40 twice a day? Or even using therapeutic doses, are they effective? There are a lot of people who are using it. There are even observational studies that report it, but we really don't have data on clinical outcomes with comparative arms. And the risk is, there's a risk of bleeding, like especially when you're using a higher dose. So as I've said at the beginning of the pandemic to even now, these are great questions. And I think we should start enrolling patients in trials, and the trials going on throughout the world to address this, rather than assume that these patients require a higher dose of non-standardized anticoagulation therapy, or even thinking using full dose therapeutics without actually knowing the harms and benefits of this. So the bottom line is, there are trials going on. I think we should encourage people to be going into trials. Otherwise, just do standard of care. What would you normally treat a patient in an ICU? What would the prophylaxis be? Or what would the normal prophylaxis be if you admit a patient to the floor? I think we should be doing the same till we have data from these trials, if we should be anything other than standard of care in terms of thromboprophylaxis.
Yeah, I think those are very important concepts. But I'd also just comment that when you see patients, the house staff love to get D-dimers, C-reactive proteins, and SED rates. I wish I knew what to do with that information, because it would make sense that these are patients who are at higher risk, that it makes sense that maybe these patients should get some kind of immune modulation. But there really isn't good data showing there's good correlation between these levels and something else. And it even goes a little further. If you have a research lab that can give you IL-1 and IL-6 levels quickly, it's wonderful to get those back. It's just it's not clear what to do with them or how you can improve outcome by knowing that data. And again, Adarsh may have something in the Midwest that they've discovered about how to use that, but we certainly don't know how to use that data, although we love to collect it and talk about it.
You bring up a great point, Dr. Masur. Again, these are all disease-oriented surrogate endpoints, right? At the end of the day, what matters is, does a drug make a patient survive? Is their disability, is their discomfort better? And it's more gratifying to see a CRP come down or a D-dimer get better, but that's not what the ultimate goal is. So I think we need studies that concentrate on meaningful outcomes for patients rather than labs that make us feel better.
Yeah, and I'm sorry, Cesar, just to mention one further point about that, and again, we'll get into this a little bit later, that in the fields of sepsis and ARDS, we have been chasing individual cytokines. We've been chasing combinations of cytokines and trying to lower them or elevate them according to what we think the pathogenesis is. That has been an abject failure for 30 years. I think it's a little bit naive to think that we're going to find one parameter that we can push up or push down and change the outcome. I hope that's true, but I fear that it's going to be much more complicated than that.
I couldn't agree more with that, and I think that's an excellent point, that we're treating patients, not lab tests, and due to the complexities of this disease. But I want to get back to one of the drugs that was being used now with some data, which is Remdesivir. And I know we are anxiously awaiting for more data on this drug, particularly more meaningful outcomes. So what have we learned at Adarsh of Remdesivir in this time, and what are we expecting to see, hopefully, when the new data comes out?
Yeah, thanks, Cesar. I think Remdesivir has, well, certainly not a miracle cure, but it has delivered for a drug that Gilead almost gave up on based on all its prior trials. And again, we have some pretty good data. Again, the first is the ACT-1 trial. If you look at the data, it did not actually decrease mortality, but it certainly got people out of the hospital or clinically improved them with at least 4 days. And that benefit, at least in that trial, was people who were on supplemental oxygen, who weren't critically ill, who are not mechanically ventilated, or who were on ECMOs. But even when I look at the data critically, and I've discussed this with methodologists, that's preliminary results at 14 days. And we all know patients who are mechanically ventilated take longer. Now, the fact that Remdesivir did not help the most severe patients, is it a biologic phenomena? Or is it just statistical? Or is it like we need the entire, I think the trial is over. I think it's beyond 28 days. Maybe it will show some benefit, including a mortality benefit. Or maybe it was not powered enough, because majority of the patients were actually patients who were on just supplemental oxygen and not. So we do have evidence that Remdesivir decreases the duration of illness, but I'm also having an open mind. I think with new data, maybe we will find a mortality benefit in the critically ill patients, or maybe I think we just have to wait for the studies. So Remdesivir certainly should be used. And the second trial, one which was published with Simple in Severe, showed that 5 days, in fact, was not inferior to 10 days. But if anything, even there was a trend for superiority in the 5 days, which I still have a hard time wrapping my head against. And I'll go into the details of that. But I do want to mention an unpublished study, which at least Gilead has put on its website, the Simple Moderate trial, where they show there was some benefit in clinical improvement with 5 days as well as 10 days, but 5 days compared with a comparator. I'm taking that with a grain of salt, because I don't have all the data for me to be critically appraise the moderate study. So until I look at the entire data, is it a meaningful outcome? Are there any confounders? I think I will say we should not be using Remdesivir and moderate. But in severe patients, I think we can use it for 5 days rather than 10 days. And my trouble with looking at the simple study that was published in NEJM is post-randomization, if you see, a lot of the patients in the 10-day arm ended up being sicker than the 5-day arm. So that's the reason the outcome in the 10-day arm slightly looks worse than a 5-day arm. So the trial, the way it was done, I think makes interpretation a little hard. Definitely saying that, okay, I think, like again, 5 days is superior to 10 days, but certainly there's enough information, especially we live in a time when there are drug shortages or limited supply of remdesivir. In non-mechanically ventilated patient, I think we can presume we can use it for 5 days. Even in the mechanically ventilated patients, I think the jury is still out there. If there's enough drug, I think we should use it, but the duration will be for 10 days. And I'd love to see data, the 28-day data and other data, especially in the critically ill, to see if remdesivir actually is useful in that population as well.
Henry, any comment?
No, I certainly agree with everything that Adarsh said. It's interesting that while I was somewhat dismissive of individual cytokine levels, it would certainly be nice if we can measure plasma viral levels, because that, at least to me, is a more plausible way of saying, here's a population with really high viral levels. They will more likely benefit from an antiviral than someone who has control their virus. Now, that's a presumption. It would have to be shown to be true. But if you looked at the sweet spot of remdesivir, we have no evidence, as Adarsh said at the beginning, that if you're asymptomatic or have mild symptoms, that you'll benefit. And we have the least data on the other end that if you're already mechanically ventilated, that you'll benefit. So if we have a limited supply or a limited budget for remdesivir, the people are on low flow oxygen, and maybe the people are on higher flow oxygen are the ones who will clearly benefit. But we need a lot more information, because I think everybody who's a clinician knows that there are all sorts of variations. Somebody who's had a short period of a short incubation period is just beginning their illness versus somebody who's 7 or 8 days into it, somebody who has a lot of comorbidities versus somebody who doesn't. So we don't have nearly enough analyses of these subpopulations so far. I think that's what we need more information about, as Adarsh said.
Fantastic. The next drug that I want to discuss, of course, that has some data, are the steroids and dexamethasone. And I want to start with you, Henry, about the use of steroids. And as a critical care physician, steroids, there are waves and coming and people using steroids in different situations. What would be the recommendation of using steroids, dexamethasone or others in these patients, particularly the sicker ones?
Well, fortunately, we have very good data on dexamethasone, but we also have to put it in a little bit of historical perspective. 30 years ago, pneumocystis pneumonia was a disease that somebody proposed treating with steroids, and it was impressive how much steroids reduced the mortality for HIV-related pneumocystis. That was a real landmark. People have tried steroids for community-acquired pneumonia. That doesn't clearly have any benefit there. They've tried it on influenza. It doesn't clearly have any benefit for influenza pneumonia, and it may cause harm. We've tried it on SARS and MERS, other coronaviruses, and although the studies are small, there's no clear benefit, and there is increased shedding, making you worry that the viral replication is enhanced. So the question is, where do we use it for COVID? And since many COVID patients develop ARDS, have we anything to learn from ARDS? Right now, as opposed to the poor results with MERS and SARS and community-acquired pneumonia, it would appear that steroids are useful for ARDS. So the question is, where does that leave COVID? And I think we need some data. The fortunate thing is with the recovery trial, which Adarsh mentioned before, I think we have some very clear information. Now, this was a large pragmatic trial that was done in the United Kingdom. It was done at many places. So they only collected a certain amount of information. We don't have all the granular details about every patient that we'd like. But if you look overall, the overall mortality of everybody who got dexamethasone in this study was improved by 3%. It went from 22% mortality if you got dexamethasone to 25% mortality if you didn't. But if you looked at those who needed invasive mechanical ventilation, there's a much bigger difference. The difference was 29% mortality if you got dexamethasone versus 43% if you didn't. That's a huge difference. And there are various issues about their mortality being higher in the United Kingdom than it is in the United States, but still is a very significant difference. And I think that we have to recognize that. We also have to be concerned, though, that while there was a huge advantage in terms of dexamethasone for the very sick patients, there was a trend towards harm in those who had mild disease. So that gives you a little bit of pause as to how to interpret this data. But I think that the size of the study and the validity of the data makes it clear that if you're sick, if you have a high dependence on oxygen, then dexamethasone is clearly, to me, the standard of care in July of 2020. And as Cesar said at the beginning, we can't be afraid to make recommendations based on the data that we have now, but we also can't be afraid to change it in the future if things look different. I just remind you, though, that dexamethasone isn't entirely benign. A lot of the patients we're seeing coming into the ICUs with COVID have diabetes, have hypertension, have cardiovascular disease. They're elderly. This is a population where the psychiatric complications, the hypertensive complications, the hyperglycemic complications of dexamethasone are going to be a real problem. So I think that dexamethasone has a clear role in those who need high flow or mechanical ventilation. In the other populations, I'm not so sure, but maybe Adarsh can provide more insight into that.
Yeah, Dr. Masur, you bring up a great point. Again, for me, especially in pandemic times, like you said, a good scientist or a physician doesn't have a cherished belief. He changes his opinion based on the evidence. And we have to go with evidence. I think this is a huge randomized controlled trial. And we have to use dexamethasone. Some limitations in the trial, though. I wish, like, assigning them to supplemental oxygen or mechanical ventilation, that the study was not designed individually to answer like the subgroups. I think, and that makes it a little difficult because all this, they randomize them, and then we are looking at these groups and we are analyzing it. So, but even with that caveat, this is a powerful study. Even in the patients who were on supplemental oxygen, not even high flows, it did show a mortality benefit. So I certainly think there is a benefit. In terms of the adverse effects, maybe I'm being an optimist, but at least in the study, there weren't that many. You're using 6 milligrams for 10 days or even shorter if they get discharged earlier. Other than the acute effects, which obviously if you're hyperglycemic, we can manage them. If they are hypotensive, we can manage them. I'm hoping, given the shorter duration and the dose, long-term consequences won't be there. But again, this is all preliminary data, and I'm hoping we will have long-term data from the current recovery DEX study as well.
Yeah, well, Darsh, just one other comment. I think you're right. There were very few complications reported, but one of the things you have to recognize about a large, which I'm sure you recognize about a large pragmatic trial, is there's only certain data that they collect. So the fact that they didn't report adverse effects doesn't mean they weren't there. And I think, again, the advantage of that trial, it was large and had very convincing efficacy. We probably need more granular data to see what are the adverse effects and in what patient populations does the benefit really outweigh the harm.
Yeah, absolutely.
And this is one of the situations when you have to deploy a clinical trial like this in a situation like this, rapid, all the information cannot be collected. And there's a very important point to make there. Adarsh, talking about the inflammation and the inflammatory syndrome that this virus seems to produce, there are a lot of molecules now being studied to target specific pathways of the inflammatory cascade. And as Henry told us, it seems a little bit naive thinking that you target one and this is gonna be the panacea or the molecule of gold to treat inflammation. So with all the trials going, what is the thought about implementing those anti-inflammatory molecules in the treatment of this disease?
Yeah, great question, Cesar. Again, for me, I think people are very, like, COVID-19 has been a different beast compared to the other respiratory infections, at least we have seen. And again, conceptually up front, you have the virus that is dominating, but after a point, people call it by different name, either call it a cytokine storm, either hypocytokine syndromes, that we know it as a profoundly hyperinflammatory response. And they've measured different cytokines, right? You have increased IL-1 levels, you have increased IL-6 levels, you have increased GM-CSF levels, you have also increased IL-17, and a lot of markers they've found. So it stands to reason, right, theoretically speaking, or from a mechanistic point of view, that if we block this hyperinflammatory response, at least some of these cytokines, that it translates into. And there were a host of agents, like the most important, or at least the most popular one, has been IL-6 blockers, like tocilizumab and sarilumab, or even IL-6, like direct, not just receptor, but even IL-6 blockers. Then we have IL-1 blockers, anakinra. Then we have the kinase inhibitors like baricitinib or ruxolitinib and a lot of other things. And even other agents like colchicine as well as hydroxychloroquine. They think the mechanism is not just antiviral, but also could be immunomodulatory. But let's take tocilizumab. I think that is the one that has got the most press. So far, there's observational data, and the last paper that was published, I think, was June 24th from Lancet, did show that there was some benefit, composite endpoints of ventilator days and mortality. But my only trouble with looking at that as this is a retrospective cohort. And when you look at the methodology, there is a scope of confounding. And selectively, some patients were given tocilizumab by their physicians, and they did okay. And we still don't have any randomized controlled trials. The one, there was a press release on late April, which said tocilizumab actually in a randomized controlled trial, the French study, I think, was looking favorable, but there were no numbers released, and so far we haven't seen anything. The only randomized controlled trial, even then, that was not published, but at least there's data available on the website, is sarilumab. And sarilumab, I think the phase 3 studies, even though upfront the CRPs looked great in a pre-planned interim analysis, and there was a trend to mortality, even though they have not published, at least they say that there was no mortality benefit on the long run. So at least for IL-6 inhibitors, there's some non-randomized or some like retrospective studies that show benefit, but most of the limited trial data does not show any benefit at this point in time. Same thing if you look at IL-1 inhibitors, same thing if you look at the kinase inhibitors. There are trials going on, and the observational data, most of the observational data shows there's some benefit. Either the benefit is in terms of improving inflammatory markers when you do lab work, or the oxygen requirements, but we really don't have good comparative trials for any of these agents that they're efficacious. So, I mean, I'm skeptical. Again, for me, I always tell, I want to see PICE and not dose. What do I mean by that? The patient-important endpoints are not just disease-oriented endpoints, especially in trials, before we start using it. I know these are used extensively even today, but I still think we need trial data. And Cesar, my own skepticism is the cytokine cascade is complicated. It's slightly interlinked. I really don't know if blocking one agent, especially in, I think Dr. Masur has more experience with septic shock, and I think the concept is similar, that blocking one agent by itself can actually result in clinically meaningful outcomes. But again, as I said, we have to believe in trials, and we have to wait for the trials to come out on this.
Henry, how about following this combination therapies of the antivirals, maybe the steroids, or one a very much more surgical anti-inflammatory?
I guess there are two ways of looking at combination. I would look at it as the question is being, should you use an antiviral and an immunomodulator? And it's interesting that when you talk to experts, you think that you're all looking at the data the same way, and yet the way they manage their patients is very variable. And the problem is we don't have data on using, for instance, remdesivir and dexamethasone. Most of the studies were done with one or the other. And the question is then, when should you use both? And of course, this is a problem in medicine in general. If you look at drugs for instance, congestive heart failure, there's probably never been a study that says we're going to use these 4 drugs in combination. You sort of take it for granted that each one is useful, and therefore 3 of them together or 4 of them together is probably better than one. So that I think with combination therapy, if you look at remdesivir and dexamethasone, I think there are some situations where only dexamethasone should be used. For instance, on patients, or at least the data would suggest that for ventilated patients, dexamethasone is clearly beneficial, remdesivir isn't. I think on the other end of the spectrum, with, as we said before, with asymptomatic or post-symptomatic people, you shouldn't use dexamethasone because that's harmful. In the middle, I think there's a lot of room for using remdesivir with dexamethasone or using one or the other. If you ask, should you use 2 immunomodulators or 2 antivirals, it would be wonderful if we had data suggesting that that kind of combination was useful, and maybe one day we will. But at this point, to me, the question is not what other drugs could we use. The question is, when do you use remdesivir and dexamethasone together? And the problem is, we're guessing. We don't have data.
For Adarsh, that's excellent points. I want to shift to other type of approaches like monoclonal antibodies and convalescent plasma, Adarsh. Where do we stand now on this?
Okay, great question, Cesar. Again, I guess we have covered the 3 buckets, right? One are antivirals, then you have a hyper-inflammatory response. How do you actually tame the fire? And now, can we use somebody else's immune system or manufactured immune system early on to treat the disease? Again, the concept for both convalescent plasma and monoclonal antibodies is similar. If you're able to, at least theoretically, target patients who are very early in the disease process, who haven't developed an adaptive immune response, passive immunity, can you give it to them? So we have more data on convalescent plasma than monoclonal antibodies. So let me start there. So if you look at convalescent plasma, it is being used extensively in the United States and everywhere else. And the last paper I looked at, Joyner's study, looked at 5,000 patients. And the safety data was fairly good in other sense. In these 5,000 patients, the number of patients who developed TRALI or TACO, like transfusion-related lung injury or hypertension, was extremely low. But again, for me, the number of patients who have improved wasn't really that different from what you'd expect in that population. So there was not a comparative arm. The only comparative study, there was one randomized control, which was so small that didn't show any benefit. Where am I going with this? I think people are using convalescent plasma very extensively. We still need trials to answer whether it is efficacious. So I'm hoping we recruit more patients into these trials. And another trouble also when we're using convalescent plasma outside of a trial setting is we simply don't know what amount of neutralizing antibodies are, at least the way that's being used. Most of the trials are targeting with neutralizing antibody doses of at least 1:160 or 1:320. So it's like a drug. Without knowing the dose, how do we use it? So the trials have to answer questions like, when should you use it? Is it effective more early on? What dose should be using it? Is it effective? And what are the long-term consequences? And at this point in time, I still think we should encourage trials and get our patients into trials using convalescent plasma, even though I know it's being extensively used. And the second question, the monoclonal antibodies, I think theoretically it's fascinating. And if you look at the data, there's in vivo data and in vitro data in SARS-CoV-2, and we can also look at MERS and SARS-CoV-1. They were able to, take specific B cells from patients and extract these antibodies and most of the monoclonal antibodies, when I looked at it, at least there are two candidates which specifically target domains on the spike protein, and they prevent the binding of the spike protein to the ACE2 inhibitor. So in vitro, they have been very efficacious. Even certain in vivo models, they've been efficacious. But we also know what can be replicated in a petri dish. Can it really be replicated in patients? There are trials that are going on. When I last did a Let's Search, I couldn't really find any clinical trial data. Like the issue I have is, again, the antibody should be actually able to make it all the way to the lungs and block the SARS-CoV-2 inhibitor in a meaningful manner. Again, does our cocktail, I think right now the antibodies achieve that end? And another theoretical concern, again, they're fairly safe, but sometimes you could have the opposite effect, like the vaccine, right? It can actually have hyperimmune reactions, or even it can increase the virulence of the organisms, and these are all theoretical concerns. So like, as I said, great concept. There's great in vitro data and even some in vivo data that these antibodies might be effective in post-exposure prophylaxis or early use. There are trials going on. We just have to be patient for the trial results if we can use monoclonal antibodies for prophylaxis or early treatment.
Excellent. The last point I want to make, and I cannot stop the podcast without asking this question, is Henry, where do we stand on hydroxychloroquine, particularly with just the publication of another negative trial in Brazil? Can you comment on this drug?
Well, Adarsh said a minute ago that there's not always a correlation between what's in the petri dish and what's in the patient. So hydroxychloroquine was a very reasonable drug to look at because there are some very interesting in vitro properties in terms of interactions with COVID. The observational studies, though, with one exception, did not show any benefit. But now we have two trials which clearly show there is no benefit and there may even be harm. One is yet to be published, but many people have seen the data, and it's the same dexamethasone study, but a different arm, which showed that for hospitalized patients with COVID, hydroxychloroquine with or without azithromycin is not beneficial. So for hospitalized patients, it should not be given. For milder patients who are also hospitalized, a study that was in the New England Journal a few days ago from Brazil also clearly shows that hydroxychloroquine should not be used. So the NIH guideline now says not that there is insufficient evidence, but that there is sufficient evidence to say hydroxychloroquine shouldn't be used. It's a very emotional issue, but if you look at the data does not support the use of this in any patient with COVID.
Gentlemen, it's been a pleasure. This has been a wonderful podcast, very informative. Thank you very much. And signing off, this is Cesar Arias, Editor-in-Chief of Antimicrobial Agents and Chemotherapy.